Thanks, everybody, for continuing on with us here in the Advances in Perioperative Care. My name is Natalia Ivascu-Girardi, and I'm one of the co-directors for this session. I unfortunately was not able to join yesterday. I was busy taking the newly minted cardiac anesthesia board exam. Just when you think you've taken your last test, they make a new one. But anyway, I'm sure everything went very well, and today we have a lot of interesting talks. We're going to kick it off with Liz Everett. Liz is really a world expert in delirium research, and we are really fortunate to have her in our department at Weill Cornell. She's going to be speaking to us today about post-op delirium. Welcome.
Wonderful. Thanks, Natalia, and thanks for inviting me to be here. And thank you all for being here early on Sunday morning. So I'm going to talk about post-operative delirium specifically, but delirium in general. So, forward. I have no disclosures regarding this presentation. So I'm going to give a bit of background and then I'll talk about what we understand about the pathophysiology of delirium, treatment and prevention, and a quick summary. So in terms of background, just to give you an idea of what we're talking about with postoperative delirium, it falls under the banner of perioperative neurocognitive disorders, which are defined according to the Diagnostic and Statistical Manual for Mental Disorders. And this was some work. It's for out there. Okay, so this is some work that we published a few years ago, and the reason for this change in nomenclature was because previously we had used the term postoperative delirium, but for other cognitive disorders we'd used postoperative cognitive dysfunction, and the problem with that term was that it was defined by a plethora of different criteria and different objective assessments, but there was no subjective component and no interpretation of what functional changes patients experienced. And obviously what's critical about cognitive changes is the impact it has on someone's ability to function independently ultimately. So that's sort of a bit of background about the terminology, but today I will be focusing on postoperative delirium and what usually is assessed during the postoperative hospitalisation period. So these are common disorders. Postoperative delirium occurs in up to 60% of patients, depending on the type of surgery, particularly common in following cardiac surgery. In intensive care, delirium occurs in postoperative patients as well as intensive care patients, and it's a real problem in intensive care. Delirium is very common. For those of you who spend time in the ICU, you would be very familiar with patients experiencing delirium. Delayed neurocognitive recovery out to 30 days, so we're talking more here about objective and subjective cognitive complaints that have an impact on function, about up to 50%, and then 20 to 30% right out until 7.5 years postoperatively. So we know that patients who experience delirium are at increased risk of further cognitive decline, increased morbidity, increased mortality, increased risk of institutionalisation, approximately a 12-fold increased risk of dementia. So for patients who experience delirium, whether that's medical patients, intensive care patients, or postoperative patients, their risk of progressing to dementia is vastly increased. And also patients have mood and trauma effects, and this is really relatively new. There has been some research done in this field in nursing publications, but very little in anaesthetic literature. And we did some qualitative work a few years ago. This was done by Caitlin Cohen, one of our honours students in my group in Melbourne. And she found that even 3 years after cardiac surgery, patients who had experienced postoperative delirium were still experiencing trauma, loneliness, cognitive and functional decline. Their perception was that this was the result of the delirium they had experienced. Many of them were refusing to undergo further medical treatment because they were so terrified, and a lot of depression. So really, I think we have to think about this not just in terms of presence or absence or severity of delirium, but also about the psychological impact it's having, not just on physiological and cognitive outcomes. Who is at risk? Those aged 65 years or more are at much greater risk than younger adults. I'm not talking about paediatric patients in this talk at all. In the US, approximately 16% of the population have 53% of the anaesthetics, and those are the people who are 65 years or more. And this is becoming an increasing problem as the population ages. So there's two factors that determine that increasing numbers of patients are at risk, and that is the ageing population, but also the population of who are at risk of having surgery and leading to delirium and dementia. We know that preoperative cognitive impairment is the leading predictor. We know that the community prevalence of dementia is about 10%, much of which is undiagnosed, and so patients in a preclinical assessment would not be obvious to you that those patients, or in any clinical environment, unless you actually assess for delirium, you won't know the patient has delirium, with the exception of hyperactive delirium. Undiagnosed cognitive impairment is common in patients presenting for anaesthesia and surgery. Between 30 and 50% of patients, when assessed preoperatively, will classify for mild cognitive impairment, where that is not a diagnosis they've received in the community and it's not something that is usually charted. So patients who are coming to clinic to see physicians or coming to hospital to have procedures in the 65 years and older age group have a high prevalence of cognitive impairment, which is the leading predictor of further decline, particularly delirium. And those who have experienced postoperative delirium in the past are also at increased risk. Associated, as I said, with further postoperative neurocognitive disorders and dementia. And it's thought, there's been a couple of publications just in the last couple of years suggesting that about 10% of the community prevalence of dementia might be prevented by prevention of delirium. So we tend to think, have been thinking about these two things in separation. So the anaesthesia and surgery happens in the hospital, that's a silo, and that's completely different to what's happening in the community with community cognitive disorders like mild cognitive impairment and dementia. But in fact, it's not. So what's happening in the community, those are patients they're the same patients, is what I'm trying to say. Okay, so what are the risk factors? I've already talked about preoperative cognitive impairment and increasing age, which is obviously not modifiable. Cognitive impairment, I'll talk a bit more about possible interventions that can not necessarily change someone's cognitive ability, but can in fact improve their resilience. And that those sorts of cognitive stimulation exercises on apps and things like luminosity actually can be really good in terms of giving patients optimisation preoperatively that will give them an increase in their resilience against poor complications. Frailty is not really modifiable in and of itself, but there are aspects of frailty that might be able to be optimised, and again, we're talking about increasing resilience, and cognitive impairment is one of those aspects of frailty. Physical exercise is another, where if patients are optimised with their physical exercise and lifestyle interventions preoperatively, it can have a really significant impact on reducing postoperative delirium. Polypharmacy is obviously modifiable, and patients should be optimised before having interventions if that's possible. And all cardiovascular risk factors such as poor exercise, poor nutrition, poor lifestyle habits and poor sleep hygiene are also risk factors for cognitive impairment and dementia. And put patients at risk of experiencing delirium in the post-op admission. So there are things that we should be actually educating patients about and doing with patients. And this ultimately needs to start way before, when people are in midlife. But but with the situation we're currently in, we at least should be optimising patients preoperatively. Just to give you a bit of an example, this is some work we did with a patient who had experienced both hyperactive and hypoactive delirium following her cardiac surgery. We did this for the Patient Safety Movement Foundation. You can take a look at that on YouTube if you are interested in the interview. What was really interesting about it was not just how Audrey experienced the delirium and the consequences, but how her family experienced that as well. It's a very distressing, it can be a very distressing situation. So Audrey said she started to panic. She thought she'd been kidnapped and tied up. And of course she thought the lines were the ropes tying her up, so she pulled all her lines out. And she then was incredibly embarrassed, and she didn't feel at any point until 3 years later when we interviewed her that anyone had named this as something that could happen and that might, that was actually not within her control. And that was a really cathartic experience for her. So just understanding is a really important component. She said she couldn't remember anyone discussing it with her. So a bit of an outline of what we are currently, the hypothesis of what the possible pathophysiology of perioperative neurocognitive disorders. It's suggested that there is peripheral inflammation, which leads to a permeable blood-brain barrier and ultimately neuroinflammation. Downstream neuronal damage, and I'll show you some evidence as to why this is our current hypothesis in a moment. And ultimately delirium and longer-term poor consequences. So to start off with, we know that anaesthesia and surgery are responsible for a peripheral inflammation, and this is a small meta-analysis we did a number of years ago. We specifically were interested in any difference between propofol or sevoflurane anaesthesia. We didn't see any difference, but we did see an inflammatory response. So peripheral blood showed increases in interleukin-6, interleukin-10, TNF-alpha, and CRP. I'm just going to grab some more. So you can see that we're demonstrating that there is a peripheral inflammatory response to surgery, which is no surprise. Just to highlight, we didn't see a difference between the two modes of anaesthetic. This is some work, and I'll present a number of studies from Rob Sanders, who's doing some really important work in this field. He originally from the UK, is in Australia now. And the work that he did demonstrated that so on the left-hand side, you can see that it's the cerebrospinal fluid plasma albumin ratio, and that's got a linear relationship with changes in cerebrospinal fluid interleukin-6. And so that's demonstrating that there is an increase in permeability that occurs with the blood-brain barrier, such that we can observe what's happening in the central nervous system by looking at blood biomarkers, which is a big move in this field. Additionally, you can see on the right-hand side that plasma S100 beta, which is a biomarker of inflammation, is very closely correlated with CSF interleukin-6, so another biomarker of inflammation. And you can see that the correlation between those two is very high. So we know that peripheral inflammation is occurring. We know that the blood-brain barrier is becoming more permeable. And we also can see that there's an increase in neuronal damage biomarkers. So neurofilament light and tau are markers of neurodegenerative diseases. They're also markers of traumatic brain injury, concussion, heavily researched in sports players. And this graph shows that the increase in neurofilament light is linearly related to the increase in interleukin-8 in plasma. So again, demonstrating peripheral inflammation leading ultimately to neuronal damage increasing in the central nervous system. And so not only are those things happening, but they are related to postoperative delirium. And this is a meta-analysis, again, by Rob Sanders' group, Sophia Wang, first author, looking at 28 studies, and they used all of the studies included, used appropriate screening tools and diagnostic assessments to look at delirium. And I wanted to highlight that what they observed was that, indeed, inflammatory biomarkers, interleukin-6 and CRP, were associated with an increased risk of delirium, as was an increase in neuronal damage biomarkers with the increase in neurofilament light. So just putting that pathophysiology that I described earlier into context with the literature that we currently have looking at biomarkers. And this is confirmed by a meta-analysis done by Ian Moppet in the UK. Specifically, this forest plot shows interleukin-6. They actually investigated a huge number of different inflammatory biomarkers. They used appropriate tools, the CAM or the CAM-ICU. They also looked at severity. And you can see in the forest plot that there's an association with increased risk of delirium in patients who have a greater increase in the inflammatory biomarker interleukin-6. And again, confirming association between those biomarkers with neurofilament light. This is a small study looking at inflammatory cytokines and neurofilament light. And what they found, this is Rob Sanders' group when he was in Wisconsin, that there was a dose-dependent association between an increase observed in neurofilament light and the severity of delirium, and an increase in interleukin-8 that was associated with the presence or absence of delirium. So again, highlighting that we're seeing that pathway of inflammation and neuronal damage being associated with post-operative delirium, which is why we're currently at the point of that hypothesis. And just to give you a bit more detail on that work from Rob Sanders, on the left-hand side, you can see the increases over post-operative days 1 to 4 in neurofilament light, and you can see that the patients who experienced delirium had a much greater increase over those 4 days post-operatively than patients who didn't experience delirium. It's still a bit unclear which happens first, so we're still a bit unknown in terms of understanding whether the delirium occurs as a result of the neurofilament light or whether the neurofilament light is a response to the delirium. So there's still work to be done, but the association. So we can't comment on causation, but we can comment on association. And on the right-hand side, that the y-axis there is delirium severity, demonstrating that increase in neurofilament light is also not just associated with the presence or absence of delirium, but in fact with delirium severity. So how do we treat or prevent delirium from occurring? So at the moment, prevention is really the only treatment, and that's really come out of a lot of work, both in the perioperative period, but also in the community by Sharon Inouye, who's the delirium guru of the world, really. She's a geriatrician in Boston. And consequently, one of the negatives that has occurred as a result of this is that there are a plethora of studies looking at preventing delirium, and really as a researcher, the focus is on prevention of delirium because there hasn't been effective pharmacological agents or non-pharmacological agents to date, other than what I'll talk about. But we haven't really been investigating treatments, and I was at the American Delirium Society meeting earlier this year, and it's a real focus. We're really trying to target, we're putting out a white paper on looking at treatments and where we should be heading, because obviously prevention is not possible in every case. And really the only treatment that is available is, in terms of pharmacological interventions, is antipsychotics, and they do not reduce the duration or the severity of delirium, so they really are not beneficial to be used, come with a lot of adverse events. The literature at the moment would say they should not be used unless there is a risk of harm. So we're really still pursuing treatment and prevention. So with regard to prevention, I'm going to I'll divide these options up into perioperative strategies, so what we can do in the perioperative period, starting preoperatively through to post-discharge, and where we're headed with non-pharmacological interventions. So first of all, perioperative strategies. I've put a question mark at the end there because there has been a recent study, which I'll talk about. I would say until 6 months ago, there was absolutely no evidence for specific anaesthetic agents, and this is some work from just relatively recently published demonstrating no difference between volatile and intravenous anaesthesia in delirium incidence. But then this study came out earlier this year, and this is work from KO, and they suggested that in fact delirium was associated with sevoflurane anaesthesia, and that using propofol led to a reduced incidence of delirium. And I present there the survival analysis looking at patients who got delirium versus patients who didn't. What I want to highlight about this is that there were a number of major design flaws, methodological flaws in this analysis, and we need to think about that when we're interpreting the results. The other thing that's really interesting is that the difference was only observed on day one. Postoperative delirium can occur up until discharge, and in fact there's some good evidence that it occurs even after discharge. So I would say that these results should be considered with caution. And my colleagues and I wrote an editorial in response to this paper, just highlighting the fact that it seemed odd that this only occurred on day one. And that we should interpret that with caution, and also, yes, that this is hypothesis generating. There's obviously a need to be doing more research in this field, but there's not sufficient evidence to change practice at this time. Severity of surgery may increase the risk of delirium. As I said, cardiac surgery has a much higher incidence of delirium than non-cardiac surgery. No difference between regional anaesthesia and general anaesthesia, which is a really interesting observation. Intuitively, you would think we would be protecting patients by not administering agents that act on the central nervous system, but in fact, there's no difference. Just to highlight that, a recent study, the Raga study, you can also look up the STRIDE study by Mark Newman from Duke, and they've both demonstrated no difference between regional and general anaesthesia in postoperative delirium incidence. Dexmedetomidine. Certainly in intensive care, dexmedetomidine has been associated with a reduced incidence of delirium. There's no question that the evidence is, as demonstrated here, that there's evidence to support its use. Whether or not it actually reduces delirium for postoperative delirium is unclear. There's studies suggesting it does and studies suggesting it doesn't. It looks like it may be an issue of timing and dose. So certainly a drug of interest, and there's quite a lot of research going on looking at dexmedetomidine at the moment. And depth of anaesthesia. This is the balanced delirium sub-study, which we undertook as a sub-study of the large balanced anaesthesia trial a number of years ago. And you can see that we demonstrated that lighter anaesthesia was associated with a significant reduction in the incidence of delirium. It's a fragile finding, and we need to do a larger study. There were geographical differences, which may reflect cultural or ethnic differences or policy differences. So there's a few things that we need to really dig into, but nonetheless, also this is inconsistent with there being no difference between regional and general. So really, interesting outcomes, but unclear what they mean at this stage. Oh, sorry, previous. So this is also looking at that same subgroup of patients who undertook a cognitive screening tool at 12 months. And you can see patients in the lighter anaesthesia group had significantly less cognitive impairment at 12 months compared to those in the deeper anaesthesia group. So this is certainly work that we need to pursue. We need to be doing more than just a screening tool at 12 months to really classify patients very specifically with the level of cognitive function. But this is, early preliminary data that supports the notion of using lighter anaesthesia. Non-pharmacological interventions. So this is some work put out by the Australian Commission on Safety and Quality in Healthcare. On the right-hand side, on the left-hand side is the Hospital Elder Life Program guidelines, and they're from Sharon Inouye. If you're interested, go to the American Geriatric Society website. They have every resource for delirium you could possibly imagine, training tools for how to assess, the actual diagnostic instruments. And what this highlights is that by reviewing medications, making sure the patients get out of bed as quickly as possible, make sure they eat as soon as possible, have their glasses, have their hearing aids, it makes a huge difference in whether or not the patients will experience post-operative delirium. This is some work by Michelle Humadon. This is a great study, and this is looking at prehabilitation, specifically cognitive prehabilitation, using the Luminosity app. And I mentioned earlier about this. This demonstrated that even if patients didn't do the required amount of training in the preoperative period, they still had a lower risk of delirium. So that idea that we can build some resilience in patients preoperatively really does have merit. And as with literature in the community with regard to neurodegenerative diseases, it's likely that joining together a number of different strategies is going to have a synergistic effect. So one strategy has a small effect size, but nonetheless an effect. Multiple strategies are likely to have a synergistic effect and increase the benefit. This is an example of really intervening with best practice. This is some work from Henrik Kellett's group, and they used a modified ERAS protocol. And their intervention, if you like, was to have the patients drinking, eating and mobilising as soon as possible post-operatively. And what they found was that there was a significant decrease in the length of stay for those patients from 8 days to 5 days, and a significant decrease of major complications. I think the really take-home message about this study is that simply by instituting best practices, we can reduce poor complications, we can reduce poor outcomes in older individuals. So it's not necessarily resource intensive, going outside what we already know. It's just about doing what we know are the best things to do already. So in summary, delirium is the most common surgical complication that older patients are at risk of. Surgery and anaesthesia initiate an inflammatory cascade, both peripherally and in the central nervous system. There's an increase in neuronal damage biomarkers, which is associated with an increased risk of delirium. Biomarkers, now that we can assay blood with high sensitivity, may allow easy identification of vulnerable individuals, so we can target our preoperative optimisation to those patients who are most at risk. Lighter anaesthesia is associated with a reduced risk of POD, postoperative delirium, but again, as I said, there's more work needed in this area. Non-pharmacological interventions are current best practice and should be instituted. And multi-component bundles of care are likely to be the most effective method for reducing post-operative delirium, and that goes for delirium in any other environment: intensive care, hospitalised patients, patients in nursing homes. So any patient at risk of delirium it will benefit from multi-component interventions. Thank you very much.
Okay, thank you so much, Liz. It's been always a pleasure to learn from you, and I enjoy always to hear your talks. Next up, we have Dr. Jeffrey Farkas, who is the president of Interventional Neuro Associates, and we're going to be hearing an interesting update on neurointerventions for acute stroke. Used to be they woke up with a deficit, and we said what's done is done. Hopefully, you'll be able to share some good news. Thank you.
Thank you. I have nothing to declare. So let's get on. Stroke is the number 5 cause of death in the United States, which is really good because it used to be number 3. So we've pushed it back a little bit. But unfortunately, it's still very common. And one stroke occurs approximately every 3 minutes in the world. And approximately 800,000 people are having strokes every year, de novo strokes. And that is expected to go quite up as our population ages. And most importantly, it's also one of the leading causes of long-term disability and costs in our healthcare system. Stroke is preventable, which we talk about all the time, but we don't talk as much about the treatment of stroke and the recovery of stroke. So let's talk about a little bit of stroke. Ischemic stroke is 85% of all types of strokes. So 15% of strokes run in the hemorrhagic stroke component. And we're going to talk a little bit about that as well. We should break up stroke subtypes into large vessel occlusions. Those are patients with a blockage in major vessels. Small vessel occlusions, ones where we cannot identify the vessels because they're too small, but they're having actual symptoms related to the same pathology. And then those who have perfusion failure, who have no blood vessel occlusions, but the blood flow is not getting to the brain. This is a typical embolic stroke, which is 85%. When I was in medical school many years ago, the professor of neurophysiology would say 6 to 8 minutes of ischemia and the brain is dead. And it's true because the brain has a high rate of requirements for blood flow. It's only about 1% of our body weight, but takes 20% of our cardiac output. And so we need to constantly refresh the blood flow to the brain. And so how is that amenable to a treatment? And the answer is, what we don't know is, what we weren't identifying at that time was that patients who have acute ischemic stroke, they do have blood flow to their areas of the brain, but the blood flow is reduced, and the degree of reduction becomes an important aspect in how we determine if they're going to do well or not. For example, this patient had an MRI and then subsequently Cs were taken out of the MRI and brought back in. And then subsequently, the radiologist saw the imaging abnormalities and wanted to get further imaging. And so within a period of 360 minutes, you could see on the diffusion-weighted imaging, which is our most sensitive MRI capability, the advent of a massive ischemic stroke, which is not recoverable. However, this patient is 4.5 hours out from onset, and on the diffusion imaging, we see a small area of ischemic stroke, and the patient has clinical symptoms that are very similar to the other patient of a right hemispheric ischemic stroke. But the blood flow, as you can see, is significantly diminished. And so in this patient, we have what we call a good penumbra. So the core of the infarct can be very small or can be very large, but the area of penumbra is which we are attacking in trying to restore blood flow to these patients. Those patients with a large penumbra can have miraculous appearing recoveries if you restore blood flow. Those with no penumbra or very small penumbras won't make a difference if you restore blood flow. So we now have the ability to identify this penumbra. And so when we talk about time as brain, and everyone talks about time and the importance of time, which is incredibly important, it's really the brain is how we determine to treat patients today is really based on what their imaging shows, what their collateral flow to their brain is, what their systemic blood pressure is, and what their capillary vasodilatation develops. And since this is a meeting about perioperative strokes, we should also talk a little bit about that as well. And what really is incredibly important when I was going through this literature is that the mortality is so much higher in patients who've had cardiac surgery and then subsequently developed strokes. So this is a population that might have a 1% or a 3% risk, depending on the type of surgery. But if they develop atrial fibrillation postoperatively, they go up to 25 to 40%. So it's incredibly important to understand how we can be helpful as neurointerventionalists in this patient population. So From my point of view, working at a hospital that does a lot of cardiac surgery, the most important aspect is, we do all the measures of prevention, identifying the patients with risk factors and trying to limit those. And is not what I'm going to be talking about today. But today, what I would like to stress is that the earlier you can get a neural exam on a postoperative patient, the better the outcome could be, because there are methods and treatments that we can provide if we identify the patient who's having the acute event. So if a patient goes to surgery, I would encourage that all patients immediately after surgery, as best as possible, is to get a decent neural exam. You might not be able to get them to speak, they might still be intubated, but you can take off their sedation, see if they're moving all four extremities and following commands. That will be huge in preventing, predominantly that mortality that we just talked about. And obviously, postoperatively preventing atrial fibrillation and or treating it with anticoagulation. One of the important things that have made stroke treatments actually improved over the course of time is imaging, and I'm going to talk a little bit more about imaging, but we are the first medical discipline that have used AI for the treatment of acute stroke, for the recognition of acute stroke. So we now have tools, and in most major hospitals they're using these tools, whether it's automatic identification of stroke on CT or identification of occlusions, or performing perfusion imaging on patients with imaging that goes directly to the practitioner's phone. Because time is such an important practice management issue of these patients, my phone goes off all the time with these types of images, and we have to review them wherever we are, maybe even right here, but not really. I'll have my partner do that. But we can get the imaging of the brain that it's not just a CAT scan of the non-contrast CAT scan. And I want to stress this. If you take a patient down who's having neurological symptoms to CAT scan and you just do a bland scan, all you're showing is that the patient has either an infarct or no infarct. Okay? If the patient has an infarct, it doesn't mean that you can't salvage more brain. And if the patient doesn't have an infarct, it doesn't mean the patient's not having a stroke. So you're not taking the physiological information that you need to be able to treat that patient. At a minimum, you should be doing a CAT scan angiogram to identifying the status of the vascularity of that patient. Is there an occlusion? Does that correlate to the neurological exam? And if it does, is there perfusion or collaterals that will keep this brain alive, or is it already dead? So we have built up a tremendous opportunity to treat patients if we image them properly. Now, I'm going to talk about TPA, but in most postoperative cases, this is not going to be something that's going to be available to patients. So TPA is a medication that has been proven in randomized trials to be beneficial to patients, all patients who have ischemic stroke who present within the first 4.5 hours. However, many of these patients who have surgery are not candidates for TPA. And many of the patients who have surgery, even if they're minor surgeries, you have to take it from the time the patient was last seen normal. So even if the surgery was 6 hours and it was a minor surgery or something that you could potentially give TPA to, you have to take the time from the patient went under anesthesia, so many of these patients will fall out of that time window. But since the beginning of 1995, and part of my whole career, I've been focusing on the treatment of intra-arterial occlusions in patients with stroke. First, we started off with intra-arterial TPA, and then subsequently moved to devices. And it was in 2015 when the devices matured enough to do a randomized trial, and that randomized trial has shown significant benefit for patients who undergo thrombectomy procedures. I'm just going to go through this. This is the device. It's a stent retriever. It's a stent on a stick. We put it inside the blood vessel and we open the vessel up with. And just to go over one study, which is critically important, is a Mr. Clean study in 2015 demonstrated a 71% improvement in good neurological outcomes for patients treated with intervention compared to medical management. 71%. The numbers needed to treat is 1 in 2 at today's level. That is better than penicillin when it first came out. Okay, it is incredibly high level of efficacy. Here's an example of a patient with a left middle cerebral artery occlusion. There should be a blood vessel over here. I don't know if you see my pointer, so yeah, I'll just use this laser here. And you can see the stent retriever is now inside the blood vessel, and it temporarily opens the blood vessel with a significant area of narrowing. This area of narrowing is where the thrombus is. And then this is after it's open. And this is the clot that basically came out with the patient. We have other tools, including, let's go back to my mouse, including devices to suction. Okay. Okay, oh, I see, all right, okay, thank you. So this is an example of a thrombectomy procedure in real time. We don't have the patient under anesthesia. The patient is moving a bit, so I apologize for that, but it definitely tells us our capabilities today of being able to open up a thrombus, and within a few minutes we can open up most patients. And the devices that we now have are the thrombectomy catheter that we talked about, the stent retriever, or in this case, we actually just use a large catheter which we're placing inside the blood vessel right here, and we're opening it up by suctioning out the clot. And so the bigger the device that goes up into the brain, the more efficacious it is at opening up the blood vessel. Today, we can open up 9 out of 10 patients with greater than what we call TICI-2B revascularization, which is 75% or more of the blood flow restored. And so this is really incredible. And then you can see in this case, in another case here, that sometimes the clot gets stuck to the end of the catheter. But this procedure is revolutionary. There are multiple trials afterwards that have demonstrated efficacy, and so this is level 1A evidence. You cannot get better evidence in medical care. So what went from a procedure that was many of my colleagues thought was cowboy back in the 2000s is now standard of care. And this is the outcomes for patients using the MRS score, or the modified Rankin score. So you can double the patients who end up in the 0 and 1 category, which is really good. This is better than the numbers needed to treat than PCI for mortality, or PCI for recurrent disease, or patient mortality. It basically is one of the best numbers needed to treat in medicine today. But it's not only about mechanically removing the clot. Sometimes there's not a problem with the clot. In this case, there's a dissection of the artery, and that's causing a problem. So we have other tools as well. So in this case, here's a pseudoaneurysm, which was throwing thrombus to the intracranial circulation, causing repeated strokes. And this patient, we laid down what we call a flow diverter, which is a device looking like a stent, and over time, the artery heals itself. So we can repair pseudoaneurysms today using non-invasive or non-surgical technology. Sorry about that. And then there are the patient, this was a patient who ended up post-CABG, didn't wake up. And here you can see the very slow flow in the right vertebral artery into the intracranial segment. And there's a high-grade stenosis of the right vertebral. And so we fixed that first by placing a cardiac stent into the vertebral artery, improving the flow. And then we went to the brain, and then you can see this high-grade stenosis of the intracranial segment here in the basilar artery, which is what is our main blood vessel that provides supply to our posterior circulation, almost non-existent, and then place another stent here. So we borrow a lot of the cardiac technology to be able to improve flow to the brain. Here's a post-stenting, and we can use a lot of this technology to improve patient care and patient outcome. This patient did very well. So I'm going to turn over to another track, which is hemorrhages. Now, we use a lot of anticoagulations in our patients, and sometimes the patients bleed, and they have alterations of mental status. So when you have a patient who's in the operating room who's being given a lot of anticoagulants, you don't know if they have a neurologic deficit related to an ischemic event or related to a hemorrhagic event, so you need to bring them down and do a CAT scan. So we can see hemorrhages that are intraparenchymal and subarachnoid hemorrhages and intraventricular hemorrhages, or extraaxial like subdural hemorrhages. And these I've all encountered in patients who have been post-op. Now, the key treatment, the medical treatment aspects today is reversal of anticoagulation as soon as possible, and aim for low blood pressure below systolic of 140. And I think that's a real key important aspect of it, is that, when you see intracranial bleeding, what you're seeing here is a moderate-sized bleed, but if the patient continues to bleed, it becomes non-recoverable. So what we can do to stop that bleeding is becoming really important in the future. And we have to, it's also a time-dependent issue because the longer you wait, the more the bleeding is accumulating. It's very slow bleeding, but it happens and it continues. So obviously, it's important to reverse anticoagulation. I'm not going to go through this chart, but each one of you in your hospitals will probably have a chart similar to this, and the stroke team is important in getting them involved. And whether it's anticoagulation with vitamin K and reversal with, if you want a reverse vitamin K agonist right away, giving vitamin K is not going to be the answer. You need to reverse it with PCCs. And also giving some of the reversal agents that are now available for the DOACs and for the and even for heparinoid treatments. These are important to give them right away and to give them in adequate amounts. We do know that if you lower their blood pressure, you can reduce the size of the hematoma. And if you can reduce the size of the hematoma, you reduce their morbidity. So the smaller you make that hematoma, the better off you are. There are minimally invasive or clot evacuations that are not available in most hospitals yet, but will be coming eventually where neurosurgery will be doing these minimal invasive treatments to just suck out the clot and restore intracranial pressures back to a more normal amount. I also want to talk a little bit about subdural hematomas, which are these extra-axial collections that happen in many of our elderly patients, and giving these patients anticoagulants, whether it's for surgery or for atrial fibrillation, increases their risk of creating further hemorrhages and increasing their morbidity from a small hemorrhage, chronic subdural to acute subdurals. And these are treated today also non-invasively with a growing level of evidence that if you embolize the middle meningeal artery, which is the artery that goes to the base of the skull essentially, and it's not a brain artery, it's a skull artery. If you embolize that, you can reduce the recurrence of bleeding, and you could also reduce and reabsorb the hematomas without surgical management. So a lot of these patients that you see in your office who have these subdurals, who might need anticoagulation, this procedure is a minimally invasive procedure that is very available to them to sort of stabilize them so that when you do anticoagulate them, you're not going to have a bad outcome. Some patients, unfortunately, about 6% of strokes are related to ruptured brain aneurysms, and sometimes we see that either postoperatively with patients who have wide swings of blood pressure who are on severe anticoagulants. Aneurysms are just saccular aneurysms are common actually in the world, and the question is when to treat them. But obviously, if they've bled, the first thing that you have to do is identify and stabilize their intracranial issues, and then prevent them from rebleeding again. The mortality from a rebleed is about 40%. So if these patients are in the ICU and they don't wake up from surgery and they have a subarachnoid hemorrhage, again, this is important for the stroke team to get involved in and to bring the patients to the lab and fix the aneurysm to prevent rupture or re-rupture. Here's an example of what we do in a coiling procedure. This is very simple. This is technology that we've been using for years now, and I would say about 9 out of 10 brain aneurysms in the world are being treated endovascularly today using the tools that we now have as opposed to open brain surgery. And the benefits are quite clear to patients. Sometimes the coils won't work because the opening of the ostium to the aneurysm is too wide, so we have technology to deal with that, including putting a stent across the ostium to prevent the coils from herniating out. And new technology exists. I'm going to skip this because that shows where you can use something called flow diversion. This is a really interesting technology, and I haven't seen it been adopted by our body people or cardiac yet. But flow diversion is really the technology of basically placing a stent with very fine tines overlying an aneurysm. And it doesn't actually close the aneurysm off immediately, but what it does do is it remodels the vasculature. So here's an example of a patient with an untreatable basilar aneurysm. It's about 6 centimeters, and then subsequently, most of it's thrombosis, so you don't see it here, but essentially, after placing a flow diverter a year later, it's normalized and regressed, and his symptoms have gone away. So, and this is an example of another aneurysm where you put a flow diverter, and you see immediately how the flow in the aneurysm has become static. It doesn't close off the vessels, and that's important because in the brain there are small perforating branches that if you closed off, if you had a complete closure of like a covered stent, you would close off those perforating vessels and that would cause a stroke. So what it does is it reduces the systolic pressures on the arterial inflow to the aneurysm, and subsequently by reducing the systolic inflow, you basically reduce the pressures for the aneurysm creation and allow for the body to heal and thrombose the aneurysm itself. At the same time, the diastolic component, which is where most of our blood flow is filling into our perforating branches in the brain, is not affected, so the patients with small perforating arteries don't get strokes from that. We've modified that technology to intrasaccular, so we can put the same flow diverter inside the aneurysm, covering the neck of the aneurysm and doing the same thing, and this is what called a woven endobridge. So a lot of this technology has come about over the last several years with tremendous applications for patients in intracranial structures with good outcomes. Many of these patients can get their aneurysm treated and go home the next day. So brain surgery with minimal amount of morbidity. Lastly, when patients do have bleeding, the interventionalist is important for identifying the underlying reason, whether it's an AVM or a vascular malformation, to prevent recurrence. And here is an AVM that we've treated with endovascular treatments. So in the last few seconds, I'm going to say that I've shown you a number of cases of ischemic and hemorrhagic stroke that are treatable and preventable, and that early diagnosis and aggressive treatment leads to better outcomes in patients. And thank you very much for the ability to talk here today.
Thank you so much, Dr. Farkas. And for our last speaker for this morning's session, we have Dr. Marga Hoyler, Assistant Professor of Anesthesiology at Weill Cornell. She's going to pick up on that theme of waking the patient up right after surgery and talk about reducing postoperative ventilation time.
Good morning. Thank you for that introduction, and I'm pleased to speak to you today about reducing postoperative ventilation in cardiac surgery patients. In my talk today, I'll address the questions of why we should try to reduce postoperative ventilation times, why this is important for our patients and also to our practice. I'll discuss the definition and significance of prolonged mechanical ventilation, and I'll describe some interventions which are data-driven in the pre and intra, but really postoperative periods to reduce ventilation time. And then finally, I'll offer some practical strategies for what can be done to move the needle in achieving even more improvements in this metric. So there are many reasons why we, as members of the clinical care team, should work to reduce postoperative ventilation times. Shorter ventilation times are associated with many clinical improvements, including decreased mortality, fewer respiratory complications, decreased rates of sepsis, decreased healthcare cost and spending, shorter lengths of ICU and hospital stay, and in the setting of all of that, comparable rates of reintubation and many other complications. So shortly stated, or succinctly stated, patients who are able to be extubated sooner after cardiac surgery tend to do much better. Data supporting these observations has accumulated since the 1990s and has really contributed to a dramatic shift in the way patients are managed postoperatively. So decades ago, it was routine for patients to receive heavy, opioid-heavy anesthetics and to remain intubated for several days postoperatively. Today, expeditious extubation is the norm, indeed to the point that many institutions will extubate cardiac surgery patients in the operating room. And while in OR, extubation is beyond the scope of my talk today, I think it's worth emphasizing the extent to which extubation timelines have really shifted dramatically over the past 2 to 3 decades. Furthermore, clinical outcomes data in favor of early extubation are so robust that the Society of Thoracic Surgeons monitors rates of prolonged postoperative ventilation. Now, prolonged postoperative ventilation is defined as postoperative ventilation for more than 24 hours, and this includes time from OR exit until extubation in the ICU. And notably, it also includes time if a patient is reintubated in the ICU. So really any mechanical ventilation time in the first 30 days postoperatively. Prolonged ventilation is one of 5 major morbidities that are factored into STS quality ratings for cardiac surgery programs. These ratings are stratified by procedure type. They're not all isolated CABGs, but certainly CABGs are included. And under this schema, participating cardiac surgery programs receive a score for each of the 4 domains shown here, plus an overall composite score, and then a star rating, 1, 2, or 3 stars. And nationally, about 20% of institutions will receive 3 stars for isolated CABG. These data are publicly available and have become a point of advertisement, a point of pride also, but certainly something which is promoted by many cardiac surgery programs. So this is yet another reason why we as a community are looking to reduce our postoperative ventilation times. Now, a nice framework for approaching decreased ventilation times is enhanced recovery after cardiac surgery, or ERACS. And this can be defined as a multimodal, transdisciplinary care improvement initiative to promote recovery of patients throughout the entire perioperative journey. So reduced postoperative mechanical ventilation time is not a singular goal of ERACS. However, it is a goal. It's not the goal, it is a goal, and it's a feature of many ERACS protocols. And as ERACS protocols demonstrate, and as I'll discuss in just a minute, mechanical ventilation times in cardiac surgery patients reflect interventions made in the pre, intra, and postoperative periods. And I'll touch briefly now on what can be done pre and intraoperatively to achieve this goal. So preoperatively, components of an ERACS protocol include patient counseling and education regarding expectations for pain, mobilization, also discharge planning. They include physical preconditioning, nutrition optimization, and smoking cessation. And then intraoperative components include an opioid-sparing analgesic regimen by anesthesia, lung protective ventilation, judicious and goal-directed volume or fluid management. And then the surgical approach can also be significant. Minimally invasive approach may be beneficial. Now, again, the goal of ERACS is not expeditious extubation per se, but these strategies can contribute to that end. And this is a recent study which I think very nicely illustrates that point. This is a retrospective review of CABG patients at a single institution, comparing outcomes before and after implementation of a comprehensive ERAS protocol. This study included 362 propensity-matched pairs, and while the primary outcome was 3-year mortality, the secondary outcomes included duration of postoperative mechanical ventilation. And this is a very busy slide presenting actually an abridged summary of the elements of this ERACS protocol. But the takeaway I want from this slide is just that it was comprehensive and multidisciplinary and extended from the pre to the postoperative periods. And many of these pre and intraoperative elements are similar to those that I previously described. Now, this study found that implementation of the ERACS protocol resulted in a 53% relative risk reduction of prolonged mechanical ventilation. And this protocol, furthermore, was associated with an increased rate of early extubation within 6 hours and a decreased rate of pneumonia. And notably, there were equivalent rates of ARDS and pneumothorax and other pulmonary complications. So these data suggest, as many other studies have, that ERACS protocols can effectively help reduce postoperative ventilation times. And so now I'll move a little bit to talk about what can be done postoperatively. To simplify this topic, I think it's useful to approach 3 different categories: postoperative sedation and pain management, ventilator weaning protocols, and post-extubation care, not otherwise specified. And I will emphasize here, as I hope is evident throughout, that really multidisciplinary cooperation and collaboration are required to achieve each of these goals. So regarding postoperative pain management and sedation, I think anyone who has taken care of post-op cardiac surgery patients knows the importance of adequate analgesia. This is for patient comfort, but also to prevent splinting and atelectasis, promote mobility, et cetera. And historically, opioids were the mainstay of post-op analgesia in cardiac surgery patients. However, opioids are associated with sedation and respiratory depression, and by contrast, a multimodal pain regimen can help avoid those complications and in turn facilitate early extubation. Useful agents are highlighted here. And although the peri-op guidelines that I'm referencing in this slide don't emphasize local and regional anesthesia, there's strong data supporting those, and there fortunately is a whole talk devoted to that subject later this afternoon. Similarly, later today, there's a whole talk on the subject of postoperative sedation, so I'll touch on this briefly and mention that there's an emerging body of literature that Precedex may be associated with decreased ventilation times in cardiac surgery patients. This study is a systematic review that was recently published in one of the top anesthesiology journals and included 41 studies which compared Precedex to propofol sedation in postoperative intubated patients. The primary outcome of this study was ICU length of stay, but duration of mechanical ventilation was a secondary outcome. And across all patient groups, not just cardiac surgery patients, there was no difference in the primary outcome. However, among cardiac surgery patients, Precedex was associated with significantly reduced mechanical ventilation times, suggesting that sedation choices can be quite impactful in this patient population in particular. The next postoperative component I'll discuss is standardized vent weaning protocols, and robust data support these protocols as a strategy to extubate cardiac surgery patients more quickly. This is one study illustrating that point. This was a retrospective review of nearly 1,600 patients, and this compared postoperative ventilation times before and after the implementation of what they called a fast-track extubation protocol. Under this protocol, patients were placed on pressure-regulated volume control mode of ventilation, which was down-titrated, targeting an oxygen saturation of 94%. And among patients who didn't demonstrate hypoxia, hemodynamic instability, or other obvious contraindications to extubation, patients were placed on a 30-minute pressure support trial, and if they otherwise met neurologic and cardiovascular criteria, again, they were extubated. The authors of this study reported significantly decreased time to extubation, and as well as increased rates of extubation within 6 hours, and then finally decreased rates of prolonged intubation, or intubation over 24 hours. Furthermore, there was no change in reintubation rates following implementation of this standardized protocol. And this is a diagram of the ventilator weaning protocol that they used. There's really nothing particularly notable about it. It's, I think, relatively simple. I post it because it's a reference for you if you're looking to perhaps amend your own institution's protocol. This is another study which illustrates a similar point about the utility of vent wean protocols. This study was a single-center retrospective review looking at the impact of one such protocol, but notably applying it also to high-risk, complex cardiac surgical patients. And the goal of this study was to evaluate if the application of this protocol was harmful in this high-risk population. The primary outcome of this study was a composite of renal failure, stroke, reintubation, and mortality, but secondary outcomes did include duration of postoperative ventilation. And one thing which is interesting here, I think, is that the authors described their mechanical ventilation protocol as the result of an iterative process, whereby over time they actually started extubating patients who required slightly higher degrees of ventilator support, and they loosened their ABG extubation criteria. The authors of this study reported that across all patients, ventilation times were significantly reduced from a little over 7 hours to under 6 hours after implementation of this protocol. But furthermore, when stratified by STS severity score, higher risk patients actually had the largest reduction in ventilation times from over 9 hours to under 6 hours without a significant increase in adverse events. And the highest risk patients, and this data unfortunately is not up here, had similar results, and again, no adverse events associated. So this study provides more data regarding the utility of extubation protocols, even in complex cardiac surgery patients who may otherwise or may not traditionally have been considered good candidates for expeditious extubation. So to step a little bit beyond the published data, I'll editorialize here for a minute. Protocols are obviously only as good as their implementation, and I will again emphasize the importance of communication, and in particular communicating extubation plans at the time of ICU arrival for patients. Furthermore, there are some studies which have described the practice of posting or documenting extubation plans in a place where all members of the team can see them. So everyone knows this patient should ideally be extubated by this particular time. And while I haven't seen these efforts evaluated individually, they are part of sort of care bundles, which have been shown to decrease mechanical ventilation times. And now a few words about post-extubation care. So obviously this is a huge category, but I would just highlight a few elements of ERAC's postoperative care protocols which might be particularly relevant. These include incentive spirometry, elevating the head of the bed, potentially hourly breathing exercises, and then prophylactic non-invasive ventilation for high-risk patients. The key point that I would make here is that if we think about postoperative ventilation as something which we need to make an effort to reduce up to 30 days postoperatively, then everything that we do in the postoperative period can be relevant to achieving that goal. So now, having talked about what we can do clinically to reduce post-op ventilation times, I'd like to pivot to how we might evaluate our success and identify some room for improvement in this area. And the bottom line, I think, is that evaluating vent times involves review of data, institutional data and outcomes. And a great source of this data is the STS database. If your institution is a member of the STS, you can access the data which you are preparing to submit to STS, and you very likely already have staff whose job it is to prepare and evaluate this data. And from personal experience, I will say that these professionals can be extremely helpful. Using these data, it's straightforward to assess absolute rates of prolonged ventilation, but the STS data also provides data regarding actual versus expected ventilation times, and then benchmarks of prolonged mechanical ventilation rates among like institutions. If you're not a member of STS, then I would propose accessing internal QA and QI resources at your institution. So STS data is extremely useful, but it really is only a starting point. I think reducing postoperative ventilation times is institution specific and requires an understanding of which patients in your ICU are most likely to stay intubated for longer and what your local practice patterns and norms are in order to identify room for improvement. I will say that having said that, it's probably good to have a sense of what the data suggests risk factors are for prolonged intubation, and there's robust data out there illustrating certain comorbidities which may predispose to prolonged ventilation. This is one such study which highlighted advanced heart failure class, CKD, and bypass duration, among other factors. But to move back to what can be done locally, I think the process of identifying high-risk patients involves essentially a targeted chart review. And this can seem daunting. Some strategies that we've implemented at Weill Cornell include breaking our review of prolonged ventilation into categories. We look at primary prolonged ventilation, we look at reintubations, and then we look at near-miss cases, patients who were intubated for 20 to 24 hours who barely met the threshold for not prolonged ventilation. And then in reviewing cases, we also look at the reasons why patients remain ventilated and what the underlying diagnosis there was. So this is an example of one of the ways in which we have presented our data to our multidisciplinary care team. In this example, we focused on cases of prolonged mechanical ventilation in a single quarter. We had 7 of those cases. We divided them again into primary prolonged intubation or ventilation versus reintubation. We then looked at the primary causes of prolonged mechanical ventilation in all patients. And then finally, parsed out the reasons why patients were reintubated, leading to prolonged mechanical ventilation. And as you'll see here, the majority of these in this data set were pneumonia. So obviously this data is just a starting point, and effective communication of the data is essential. Fora for communicating this data include division meetings of the surgical and ICU teams, also quality assurance meetings and quality improvement groups at your institution. And I'll just say that the data I just shared has helped inform some initiatives we've taken in a multidisciplinary fashion to help prevent and better manage postoperative pneumonias to reduce the likelihood of reintubation. So by way of conclusion, I would like to emphasize that avoiding prolonged mechanical ventilation is important, both as an STS quality metric, but far more so because it is associated with dramatically improved patient outcomes, that protocols may be applied to many patients, even most patients. These are ERACS protocols, but also isolated vent and sedation wean protocols. Beyond that, additional improvements in mechanical ventilation can be challenging. They can require case-based analysis and targeted interventions for specific patient categories, but progress can be made, and doing so does require interdisciplinary cooperation. Thank you.
As you know, we got started late, so now we are way behind. So why don't we have the speakers will stay here, and if you have questions, I'd encourage you to come up and ask them. But we'll take a 15-minute break, and then I'll just put us slightly behind for the next session. You get a chance to see the exhibits and get a quick coffee. So thank you, and thank you to all of our speakers.